we'll go ahead to our next speaker, who hopefully is out there. I don't see him. Anobel, there he is.
I'm here.
Okay, great. So Anobel Odisho is a urologist actually and epidemiologist, and he is in the works is a contributor to the UCSF Center for Digital Health Innovation, which Keith mentioned earlier as being part of the precision medicine ecosystem here at UCSF. And Anobel is has a particular interest in the use of electronic health records in research, and we thought it'd be a nice segue from Michael, who is really coming from more of the traditional clinical trial world, how to adapt our clinical trials structures to answering these questions, to looking at the use of electronic health records, which is obviously a very, very important topic. Anobel, thanks very much for coming to speak to us. I also want to mention that Anobel is he's a faculty member in the Department of Epidemiology and Biostatistics, where he's teaching a course right now on electronic health records. I'm actually a student in this course. I can tell you he's an excellent teacher. I'm not saying that because he's grading my final project next week. But Anobel, thanks so much for talking with us today, and we'll have you take it away.
Excellent, Connor. Thanks so much for the great intro. Explains why a urologic oncologist managed to waltz into a room full of orthopedic surgeons. So thank you for having me. In addition to urology, I'm also board certified in clinical informatics. Probably one of the few urologists and surgeons here. So I want to talk a little bit about using the electronic health record for clinical research and how we can stop being victims of the EHR and try to gain some actual benefit from it. I think the first thing to really understand is, what are all the different functions of an electronic health record? We think of it as the kind of the system that we interface to take care of patients, but there's some discrete functions. And so we'll start with the foundational systems, the ADT, which is admission, discharge, and transfer, your master patient index. And these are things that are going to be pretty accurate, right? It's hard to lose a patient within our system, at least on paper. On top of that, there are a lot of departmental systems, so radiology, the lab management system, so managing specimens back and forth, pharmacy for distributing medications and filling orders, and tracking inventory and packs. And then the yellow portion is what we feel and see the most. That's where we review results, put in our clinical notes, do computerized order entry, potentially get some decision support, and every clinician's favorite, the inbox, for messaging back and forth. And each of these has particular strengths and weaknesses when you're thinking about the type of data that you want to get access to and use. Now, this is just the kind of data flow for the electronic health record, and this diagram is specific to our EHR, and these names here in the boxes are just what the vendor has given, arbitrarily named their components. But the overall concept is the same across multiple EHRs, which there's one database which is kind of real time for using the EHR for clinical care delivery. And then from that, each of these arrows is a process where some information is extracted into another database. There may be a delay, maybe 24 hours or sometimes longer, and that's for reporting. That's where when you're accessing and pulling data from the EHR, you're going to be spending most of your work, because you don't want someone to write a query that slows down the entire system and then impacts patient care. And then the next jump is to something called the data warehouse, which takes information from multiple different sources and is a little bit easier for writing reports out of. And so you can take third-party data and incorporate it there. And this figure briefly is the UCSF data landscape. You can take a look at this at data.ucsf.edu. I just want to show kind of one key flow, which is these three boxes are our electronic health record systems, the current and the legacy ones. They get moved into one reporting database and then into a data warehouse. The key issue here is images and clinical notes are in a separate database. And then this red line is the junction between identified and de-identified data. We have lots of various de-identified data sources. And whenever you're doing a project with EHR data, you really want to ask yourself, do I need identified data? Because if you can do it with de-identified data, your life is going to be much, much easier. Accessing the de-identified clinical data warehouse takes 24 to 72 hours, and you don't need an IRB, and you can get up and started. Whereas if you want to use identified data, you've got to go through IRB, brokers, privacy concerns, security, etc. So really ask your question. Ask yourself, can I get away with using de-identified data here? The other option is you can design your study using de-identified data to get up to speed, do some preliminary analyses, and then as you're going through the IRB process, run the same queries on the identified data once you get approvals. We're lucky here at UCSF because there's been a lot of investment by the enterprise analytics team, by the Baker Institute to get all of these resources up and running for us. We talk a lot about structured and unstructured data, and generally structured data are things that exist in fields, like cells, tables, rows that you can get at, codes, labs, orders, etc. Unstructured data is clinical notes, the images, reports, some patient report outcomes, photos and videos, scanned documents. So these are things that could contain a lot of valuable information for us, but unfortunately, they're just not easily accessible. It's really time-consuming and expensive to create structure from unstructured data. It's possible, but time-consuming. And so whenever you're designing your study, you should try to track the data elements that you need and where they exist to think about feasibility. Now, the EHR does have some strengths, especially around discrete events that happen here within our control that we do and are within our system. So you can consider an inpatient order for medication. You know who ordered it, when it was filled, and even when it was administered by the nurse, and that's all very carefully logged. Whereas an outpatient medication, you order the medication and it goes off to some pharmacy. You have no idea if it was filled, you have no idea if the patient took it, if they were compliant with the medications. The other strength is a lot of the data, because it's passively collected, it's relatively cheap to obtain and access, and it is near real time. So, 24-hour delay, and there's a lot of it. The volume can solve some problems such as random bias or noise, but not necessarily some of the systematic bias and errors. And there are a fair number of weaknesses as well. So the transactions in the EHR may not reflect what actually happened. Lots of orders end up getting canceled or don't get filled, or they're duplicate orders, or you place an order internally, but it gets filled at an outside radiology center. So you need to be wary of that. There are also a lot of changes in the EHR system that impact how the data are stored and generated because of how we as physicians or providers interact with the EHR. So, we didn't have computerized order entry at UCSF until 2015, right? So a lot of those things are missing if you want to do an older study. The other issue is when there's a clinical condition in the EHR, how do you differentiate when it actually started, let's say asthma, versus when it was first noted? The identifying your cohorts can start getting quite complex as you go through the various ICD codes that you need, the procedures, your inclusion and exclusion criteria. This is something that's a really great place to work in the de-identified data warehouse, do some preliminary work to figure out how many patients you could potentially have in a study. And there's a fair amount of missing data. Some fields just aren't used, even though you really, really wish they were, or incorrect data. So I'm sure if you look at respiratory rate for patients in the hospital, it would be 98% of patients would have a respiratory rate of like 16 or 14, whatever people are used to entering. The other piece is context. So there are a lot of clinical issues that we're interested in that you need to link multiple fields together in order to have some meaning. Let's say in prostate cancer care, we're really interested about the date of diagnosis. Well, what is the date of diagnosis? It's usually the date of the very first positive biopsy. So you have to track down that first positive biopsy and then generate a date of diagnosis from that. We also want the last the diagnostic PSA value, which is the most recent PSA value before the date of diagnosis. So now that you've generated your date of diagnosis variable from the EHR data, you don't have to generate all these various supporting variables. So that can be quite time consuming. And the volume is a strength, but it can also be a weakness because you can be lulled into a sense of data, a sense that you have much more usable data than you actually do as you start winnowing down your cohort, and it can be time consuming to work through all that. So some key pitfalls in the research studies that we do, our medical interventions, they're not random. Physicians order things for a reason. And so there's a significant confounding by indication. Our data collection isn't systematic at all. When a provider or someone using the EHR decides to enter a piece of information, is going to be biased by the clinical scenario. So let's say family history. If I'm seeing a patient for prostate cancer, I may document a negative family history, but all the other patients that are not being seen for prostate cancer, no one's documenting their family history for prostate cancer specifically. We have a lot of incomplete data, so we're only seeing their experience in our system. And the data quality, again, depends on the mode of entry. There can be things that are mistyped, or a lot of data fields, people just click through to get to what they want to do. And so you can't necessarily trust that field. Let's say the reason that a medication was canceled, that prompts up for the provider, but most providers probably just hit the first thing that comes to mind so they can kind of get that prompt out of the way and move on to their work. So you have to really understand how that data is generated, where it comes from. There are a lot of workarounds, and I'll spend the rest of the few minutes talking about that. One is design your study so that you're asking questions that can be answered with EHR data. You might not want to design an outpatient medication compliance study with EHR data. You can take a hybrid approach, so you're going to need to collect some data manually, but be aware of what you can pull from the EHR to make the manual data entry much quicker. And then the last piece is making the EHR your friend and working prospectively to change aspects of the EHR and the clinical workflow to support that. So there are a lot of existing structured data fields that we can use. An example of that is when we do partial nephrectomies in urology, we clamp the renal artery and we're really interested in the warm ischemia time. That was traditionally in the operative notes, and you'd rely on someone to go back through the charts and track down the ischemia time. However, there is a field for clamp time on and off, and we work with our OR staff and our circulators so that when we place the clamp, they document that in the EHR. And so now that's available to us as structured data. We can create new data entry mechanisms in the EHR, and I'll show you some examples of that, and then doing some text parsing and also integrating PROs more effectively. So in urology, we use a lot of smart data elements. These are when you work through your clinical documentation, there's the yellow drop downs in Epic. You select something and then that gets saved as a structured data element. We work prospectively. We've created about 500 of these smart data elements and we've integrated them into our clinical workflow. So when you document a new patient visit, that information will pre-populate the operative note, such as the indication section. And then when you enter things in the operative note, that'll pre-populate your post-op note. So it does speed clinical documentation while improving passive data collection, and it's customizable. So we have about 500 of these across oncology and benign urology. Our prostate cancer smart data elements and our nephrolithiasis smart data elements are an Epic foundation. That means any Epic customer can just turn that on. And so we're using this for kidney stones. We have a multi-institutional registry, and we currently have 5 sites using the same smart data elements, and then we're able to easily collapse and bring all the data together. And just for stones, we have about 245,000 data points here at UCSF. I think 98% of our kidney stones patients have smart data element notes. The other thing that we do is some natural language processing for things that are to get structured data out of unstructured notes. We do parsing for prostate biopsy and prostate MRI reports, and this is a rules-based approach. So we get for each biopsy core the specific Gleason scores, the length of tissue, how much cancer, etc. It's slow to develop, it's brittle, meaning that as the underlying structure changes, the notes, the quality of your data extraction can be diminished, and it's expensive to maintain. But we're doing this for select notes like prostate biopsies and MRIs. And so every night we extract the text into our data warehouse, we run our algorithms on the newest notes and populate our database. So we're about 48 hours behind real time. For radical prostatectomy, of course, we're using machine learning based natural language processing approaches because those documents have changed a lot more over time. And so again, we used a couple different NLP algorithms, and every night the reports get pulled in, parsed, and populated in the database. The key here, which is really important for us, is not only are we getting the label for what each variable may or may not be, but we also have a predicted probability of confidence from the algorithm, so that we know some of these that the algorithm thinks it's really confident for, we can use them for those that are lower. So let's say extraprostatic extension here, and this is for each specific patient, those can get flagged for manual review and confirmation. And then the last piece is getting better patient-reported outcomes data. You can see this is for a few of the really important PROs that we use in urology. We have a lot of great pre-treatment PROs, about 4,300 in this specific one, but at 6 months, 12 months, 24 months, there's a significant drop off. And I know there are a lot of different efforts to get PROs from third-party systems into the EHR. What we did is worked with the Epic Builtin tools. And so using MyChart, our MyChart utilization is about 90% now within our practice. And so for patient, we tied sending specific PROs at specific intervals based on the combination of either visit type only or diagnosis and visit type. And so patients get sent those before their visits through MyChart. And then we also have a separate report that goes out to our clinic staff every day for, and it looks like this, for which patients have appointments that day, by their appointment time, and whether they're overdue for a specific PRO or not. So we can really work on improving compliance. So in summary, I think EHR data, it's cheap, messy, and problematic, but it can be incredibly useful. We can create structure out of unstructured data retrospectively, but it's time consuming and expensive. And so if you work prospectively, and that's a combination of making some changes to the EHR, working with your practice and staff and OR team to change the workflow, but also making sure that any changes that you make actually speed the clinical workflow to make sure that people continue to use it. And I will say our uptake of our notes was actually significantly improved once we got scribes, because it's really hard to convince our faculty to change their ways. But with scribes, we just say, this is your job, and this is the note that we have to use for this patient. That's really been an improvement. Excellent. And with that, I'll stop and open for questions.
Yeah, thanks so much. That was great. And there's so many lessons there that we could learn for our department. Matt Callahan, can you unmute yourself and ask your question? Because this is something you spent a lot of time thinking about.
I think I talked to you a few years back, but the question is just how easy is it to implement these new smart data elements, both from a technical standpoint and then working through permissions within the university for setting them up?
The technical standpoint is very easy. If there's an Epic builder, you can build one. They create one of these in about 5 minutes. It takes no time. The other piece is the UCSF organizational permission and getting resources to do it. We built a lot of these back in kind of 2015 at early Epic days, where it was a little bit of a free-for-all. But every time there's been a clinical documentation effort, we're in the middle of one right now, where in kind of embedded into going into self-coding, they assigned us a builder to update our note templates. And so we use that opportunity to not only change our note templates, but update and build out new smart data elements. So it's trying to get it done through the Epic team. You can put in change tickets. Right now, that's probably at the bottom of the list, but I think with enough push that can get done. And then question about how PROMIS is connected to the EHR. So the clinical systems team at UCSF has committed to building out all the PROMIS measures within MyChart so they can be sent out as MyChart questionnaires. I don't know how far they are of the 400 they built out, but if you can look. The best way to see which ones are available from an end user is if you pretend to send a message to a patient, a MyChart message, on the bottom right, there's a little button for attach questionnaire. And if you hit that, you can just type PROMIS and you can see all the measures that are available. And if there is a specific one that the practice is interested in, I'm sure you can try to get that bumped up the list. But again, that's dependent on a patient using MyChart and entering the data in through MyChart. There are a lot of third-party tools that make that easier, at least, improve patient engagement, but getting the data back into Epic is a big challenge.
Thanks. Just a quick follow-up on that. Do you know if the PROMIS questions are computer adapted, or is it?
They are. The ones that are built into MyChart are. And the Epic Foundation data fields. Stefano, what do you mean by that?
When you were talking a little bit earlier, you said that, well, first of all, thanks again for the presentation. Always great to talk to you and hear the work you're doing. So I was taking some notes, and you said that you were able to collect customizable data, and that you created a bunch of fields that could be used and shared across instances of Epic with other urology services or oncology services. And that was actually an interesting question, because if that is the case, because just as was pointed out, the complexity of building these into Epic isn't so much the workflow, it's the access to the platform to make those changes. And if those are already built in, and there were, say, for example, or UCSF decided to do a multi-center study across multiple Epic integrations across the country, and we all collect the same data elements are all built into the same notes, that sounds kind of interesting, actually.
Yeah, let's chat offline about how that was done. But the overall concept is, Epic doesn't have a lot of physicians, and so they have no clinical context. And so when they hear from all of their customers something they're doing that is interesting, they'll try to kind of absorb it into the rest of their work. So we built these smart data elements with our builder and collaborated with Epic to get them to put them into what Epic Foundation is. It's like the base Epic software. So every Epic customer now has it. So it's easier for them to just flip a switch and turn it on. We did it for prostate cancer and for stones. I don't know what they're doing across other conditions, but I can, Matt Cooper did it for prostate cancer, and Tom Chi got it built out for stones. And I don't know who their contacts at Epic were to get that done. But our prostate cancer notes are also built out into Epic Foundation, and that has now become the core. Where American Urologic Association has a quality registry called Aqua, which is meant to be nationwide. And so any practice that wants to get into the quality registry that's on Epic can use these, and it's an easier way for them to get into it.